potentially be a fourth MLR in addition to the fact that we have to follow federal MLR. And then, of course, the Commissioner has a bill that's in the Assembly right now that would establish a fifth MLR, an overhead loss ratio. So our concern is that we get some clarity in terms of the conformance to ACA, and that be very, very clear in the bill. And I'm not quite sure it's there yet. The last thing I want to mention in terms of maybe some inconsistencies is that the bill does exempt specialized health care service plans and insurance plans, and that's good because vision and dental are not included in the ACA. But the way the state has interpreted those kind of exclusions, if it's not cited back to those plans that are exempted under the ACA, those are called HIPAA accepted benefits, then the state would impose a state MLR only on those HIPAA accepted benefits. So there are a number of areas that we'd still want to work with the author on, and so we can't remove our opposition today, but we do really appreciate the understanding that we have to conform with the ACA, and I appreciate that.
Thank you. Before we go to the next individual that's in opposition, let me just kind of answer one of your questions with regard to the federal law portion. It's my understanding, and I just checked it right here in the bill, that it does reference Section 2718 of the Federal Public Health Service Act, /42 U.S. Section 300 GG.8. What I will do is I will have my staff talk to you about it just to make sure, so it does, reference it. So there is no conflicts. And with regard to the emergency regs, I believe you had a concern. I don't think there should be a problem as well, but I will have my staff talk to you about it. If you have every right to continue to oppose it, but we should be able to address a little bit more of your concerns.
I appreciate it.
Yes, next.
Thank you, Mr. Chair. Members, Nick Luizos, California Association of Health Plans. We want to echo a lot of the statements made by ACLIC. We do want to thank the chair, his committee staff, and the author for the level of engagement on the bill. We've had some productive conversation about the importance of being in conformance or in conformity to the new federal health care law, and a number of complicating issues have been addressed in the bill. Long story short, health plans are working hard to comply with the ACA. We are constructively engaging in state-level implementation bills, but if there's any ambiguity or duplication in enforcement or implementation, it causes a implementation burden on our member plans. And we don't believe there's a good public policy reason that state-level implementation bill should go beyond any federal requirements in law or federal guidance. So we want some time to review the amendments. We do believe we're headed in the right direction. Thank you again. But unless the bill conforms to those requirements of federal law and guidance, we must continue to oppose the bill. Thank you.
And again, let me reiterate, in my opinion, it does not, and it does conform to federal law. Yes, next. Thank you.
Mr. Chair and members, Maureen Higgins representing Anthem Blue Cross and America's Health Insurance Plans. This ditto what Cap and
Thank you.
said.
Hi, Dan Chick with HealthNet. I'd like to associate our comments with those of the prior testimony. Thank you.
Thank you very much. Anyone else in opposition?
Support. Mr. Chair, I'm sorry. Actually, I'm here in support.
Okay, no problem. Please state your name.
This is Alice Lowe representing California Senior Legislature, and we have more than 10 members here in support of Senator Elquist's bill.
Thank you.
Thank you so
are
much.
they going to come up and state their position, or you just wanted them to notify that they're here? Okay. Thank you. Hello.
I'm Billy Taylor with the California Senior Legislature, and I support the bill.
Thank you very much. Is there anyone else that'd like to speak either in support or opposition of the measure? We have a motion to move the bill by Senator Woke. I'd like to thank the author for taking this very, very important issue. To me, this is just one step closer to implementing the PPACA, or the federal health care bill, dealing with the medical loss ratio. And thank you for also committing to work with the plans to ensure with regard to the discrepancies bill rebate timeline frame. So I appreciate that. So we have a due pass as amended, 2 appropriations moved by Senator Woke. Can we have the Secretary please call the roll?
Senator Hernandez?
Aye.
Hernandez, aye. Strickland? No. Strickland, no. Alquist?
Aye.
Alquist, aye. Anderson? No. Anderson, no. Blakesley? Blakesley, no. De Leon? DeSaulnier, Rubio, Wolk. Wolk, aye.
Thank you, members, and I'd like to thank the chair and his staff.
Thank you, Senator. You're doing a
Appreciate
great
working
job,
with you.
and I appreciate everything that you're doing.
Thank you.
The measure has 3 yeses and 3 nos. It's on call. We will lift the call when we get the rest of the members here. Thank you.
And I have one more bill.
Please proceed.
Thank you. This is SB 222, Local Health Plans, Joint Ventures. In 2014, people will be required to obtain health insurance. Many working families find it difficult to afford health insurance. To meet the federal mandate, Californians need innovative and affordable options to get health insurance. Local health plans, such as the Medi-Cal local initiatives and county organized health plans, the COES, have the potential to provide cost-effective coverage for low-income residents. However, these local health plans lack clear statutory authority to form joint ventures to provide health coverage in the individual and group insurance market. So basically what this bill does, it provides authority for local health plans that are owned or organized by counties to form joint ventures or joint coverage arrangements to provide health insurance coverage to individuals and groups on a regional or statewide basis, and there's no cost to the state.
Thank you, Senator. Please proceed.
Beth Capel on behalf of Health Access California. In support of this measure, we have seen this measure before. The idea is fairly simple. We have county-based Medi-Cal managed care organizations that provide coverage to people on Medi-Cal and people on healthy families. But it makes no sense that you have coverage when you're in Santa Clara, but if you go to San Mateo or Hayward, you don't have coverage. This would allow or if you happen to live in Covina and work in Pomona or Corona, that you don't have coverage when you're away from home. This bill would provide for regional joint ventures or statewide joint ventures among these county-based Medi-Cal managed care organizations so that they can provide care both to people on Medi-Cal, to people in healthy families, and to people who are receiving who are covered by the exchange. It's a modest measure to build on what California already does. And for that reason, Health Access is in support.
Thank you. Next.
Sarah Flocks from the California Labor Federation. We are also in support of this bill. We think it's a common sense measure to make sure that affordable care is regionally available to people who need it. And so we are in support of this bill and urge an aye vote. Thank you.
Thank you.
Barbara Blake from United Nurses Associations of California, 20,000 nurses and nurse practitioners, PAs in Southern California. And we request your support of the bill.
Thank you. Anyone else in support? Is there any opposition to?
Brandon Pittman, Planned Parenthood Affiliates of California, also in support.
In support. Thank you. Opposition?
Mr. Chair, members, Brian Lundgren on behalf of the Orange County Board of Supervisors, with all due respect, oppose.
Thank you very much. Any other comment? Any comments from the members? We have a motion to move the bill. Senator Wolk, I am seeing no questions or comments from any of the members. We have a due pass to appropriations. Secretary, call the roll.
Senator Hernandez?
Aye.
Hernandez, aye. Strickland? No. Strickland, no. Alquist?
Aye.
Alquist, aye. Anderson? Anderson, no. Blakesley?
Aye.
Blakesley, aye. De Leon? DeSaulnier? Rubio?
Aye.
Rubio, aye. Wolk? Wolk, aye.
Thank you, Mr. Chair and members.
Thank you, Senator. That does have 5. It passes. We will still hold it, put it on a call, and lift the call so the other members can add on.
Yes.
Senator Pavley, we are back into special order of business. I appreciate it. Let me just reiterate, and specifically with this bill, and
Could I just interrupt 1 minute?
Sure.
I had some witnesses for my physician's assistant bill that we're.
Oh, so you want to do that one first?
Is that okay?
No problem.
That'll be probably briefer. I don't know.
No problem. So we're going to be.
That I would appreciate that.
We're going to do then item number 9.
Senate Bill 233.
Correct. Item number 9, Senate Bill 233, Pavley, Emergency Services and Care. Senator Pavley, I believe we have some amendments, and
Yes, we do. We have committee recommended amendments on page 5 and 6, and an additional one that was brought to my attention at the request of yourself on page 4, lines 28, 34. It's just a cross out of one language and a substitution of physicians and surgeons and acting pursuant to their scope of practice.
okay.
And I would be glad to accept those as authors of amendments.
Thank you, Senator Pavley.
All right. Does that cover it?
Yes, thank you.
All right. Very good. I wanted to just start by stating for the record it's not my intent in this legislation to expand or restrict scope of practice in any way. That's not the point of this bill. It is my understanding, in fact, that the Business and Professions Committee has determined that the committee's proposed amendments do not change existing scope of practice, and therefore this bill will not be heard in that committee, and they have not requested it. That being said, I do understand that there's still several stakeholders that may have lingering concerns today, and I'm more than happy as the bill moves through the process to work with them and all interested groups as it moves forward. There's been a very good group of concerned parties on this bill that have worked collaboratively together, including your staff and yourself, and I appreciate that, and I'm confident we can reach an agreement. So what does this bill do? Well, it came about because of an incident in Southern California where a PA, a physician's assistant, was prohibited by the hospital from providing a consult in the emergency room. And as you know, PAs are authorized by being under the guidance of a supervising physician to consult and give treatment services. But there's sort of a loophole in the law in that it doesn't explicitly authorize a PA or nurse practitioner or other mid-level practitioners to perform such consulting and treatment in an ER setting, and that's what this bill does. Sort of clears up and clarifies that definition. So the bottom line is PAs help increase access to health care. It's a growing population of service providers, very much needed in urban and rural and underserved communities, and particularly in emergency rooms. So I have with me today the sponsors of the bill. We'll get to the gist of it right now. From the California Academy of Physicians Assistant, Bryce Doherty and Beth Grivet.
Thank you. Please proceed, Mr. Doherty.
Mr. Chair, members, Bryce Doherty on behalf of the California Academy of Physician Assistants, the proud sponsors of the bill. I just would like to reiterate what the senator said. I just want to thank you, Mr. Chair, and your staff and the committee staff. There's been constellation of amendments and mock-ups and stakeholder meetings, and particularly over the break last week. So I want to thank you for that. I think we're moving forward with a bill that still meets our intent, which was finding that physician assistants were prohibited under state law from providing those functions in the ER that they're authorized to do in their existing scope of practice and are authorized to do under federal EMTALA law. I think we're getting a little bit closer on those issues. The bill now, not only being a PA bill, also includes registered nurses and nurse practitioners. Those are the 3 levels of mid-level providers that are providing services in the ER. And with that, we're proud to support the bill. With me today is Beth Grivet, physician assistant practicing in Orange County.
Thank you. Welcome.
Thank you. I'm Beth Grivet. I'm a physician assistant in family practice in Orange County. And yeah, I just wanted to clarify that there's basically 2 areas that we were hoping to clarify by introducing this legislation. The first is that to explicitly state that physician assistants can provide treatment in the emergency room, and that physician assistants can provide a consultation both under the supervising physician that they work with.
Thank you. Next.
Barbara Blake from United Nurses Association of California, and we represent PAs, RNs, and NPs in Southern California. We urge your support of the bill.
Thank you. Anyone else would like to speak in support? Is there anyone in opposition?
Mr. Chair, members, Tim Madden, representing the California chapter of the American College of Emergency Physicians. Our position is opposed unless amended. I have with me today Tom Sugarman, who is an emergency physician, who will go into some of our concerns. But before I start, I just wanted to thank the chair and his staff, as well as Senator Pavley and her staff and the sponsors and other stakeholders for working with us on our concerns that we've had. As the sponsors mentioned, we've had multiple meetings, and we've always had an open door with those folks to meet, so we appreciate that. I think we are moving in the right direction, and we look forward to working with the senator and her staff and the other stakeholders as the bill moves down the road. With that being said, I would like to have Dr. Sugarman spend a few minutes talking about some of our concerns that we have.
Thank you, Mr. Chairman. My name is Tom Sugarman. I'm a practicing emergency physician in the East Bay, and I represent the California chapter of the American College of Emergency Physicians. Our concerns with this bill relate to patient safety and access to emergency care for all Californians. The rules as specified in 1317, which is the law being amended by Senate Bill 233, pertain to ensuring that all patients have access to emergency screening examinations, necessary emergency treatment, and then consultation if needed, and that access be without regard to their ability to pay or any other discriminatory issues. We're concerned that if the bill goes through the way it's currently written, that there's potential for limitation to that access and potential for impact to patient safety in a negative way. And so we're asking that the bill be amended in the way that we've discussed with the sponsoring organization and Senator Pavley's office. For example, under the current version of the bill, a consulting mid-level provider, for example, a physician assistant, could determine that medical stabilization had occurred and there's no longer an emergency condition, even if a bedside emergency physician who's actually seen the patient did not think so. So, for example, a patient could come into the emergency department, be seen by an emergency physician or an emergency PA, and then be found to have a severe soft tissue infection or kind of in the popular press, the flesh-eating bacteria. Now, oftentimes these patients look relatively good initially. They don't look very sick, but if they don't promptly receive surgery, then they're going to get very, very sick and potentially die. And the treatment for this is not antibiotics alone, but is antibiotics and surgery. So that potentially, if the physician assistant on either the telephone or in person didn't agree with the emergency department physician, then it would be quite ambiguous as to whether or not the emergency department physician could require that the consulting physician come in and personally evaluate the patient. And there's this kind of saying in medicine that being at the bedside is worth any conversation or any other data. So what we're asking is that the state require that for patient protection purposes, that if a treating physician at the bedside feels that a physician level expertise is needed, that physician, the consulting physician, has to come in and personally see the patient to make that decision and not do it via proxy. Our other concern is with who determines what's an appropriate practice at an individual hospital. We feel that it's important that the medical staff, the hospital, the nurses, the physician assistants, nurse practitioners, together collaboratively decide who can provide this screening examination, emergency treatment, and consultation. It's not really a scope of practice issue. That's not how we're viewing it. We're viewing it as a patient protection to ensure that nobody decides unilaterally that it's acceptable to delegate responsibility to a less expensive form of care if the collaboration of those groups doesn't agree that that's a safe thing to do in that particular practice setting. So that's kind of the gist of the amendments that we're suggesting to make this safe for patients and appropriate for California.
Let me just interject real quick and ask you a question, and maybe have the sponsors of the bill, respond as well. But my understanding is that a physician assistant can't unilaterally do anything on his or her own unless it's under the supervision of a medical doctor. Is that correct?
That's correct.
Okay. So, how are the last concerns? I thought ultimately you have the prescribing as well as the right to dictate the medical care. So how would you respond to that? His concern, his last concern.
And I believe under federal law, the ER doctor can require that the supervising physician actually come to the emergency room and not rely on the PA.
And that was going to be my next comment, because my understanding is that if the patient requests the physician, that it's already under federal law that has to be, stated and done. Is that correct?
So in response to, I think, your first question, which was the patient example I gave, the concern we have is that if I, as the emergency physician, feel that a physician is needed, but I'm consulting a physician assistant, for example, or a nurse practitioner, I'm not trying to pick on any particular group, that if they disagree with my assessment, we want to be able to ensure that we can get a physician-level response if that's what's needed for the patient. And because other areas of California law appropriately say that the nurse practitioner or the PA is standing in for the physician, then without this protection in this particular area of the law, which refers to emergency medical screening and treatment, then it could be interpreted that the PA has now taken the place of the consulting physician, and then it's really quite ambiguous as to what would happen at that point. Me, the emergency physician, says they need something else. The consultant on the consulting PA on the phone or in person says no, they don't. There's a lot of ambiguity there. Now, that ambiguity does exist between consulting physicians and emergency physicians, and we usually try to work that out, and I understand why the law can't regulate that. But it seems to me, and it seems to our organization, that a physician who is requesting a physician-level consult should be able to get that in the interest of the patient. Now, with regard to your second question, the first part of it is that I'm not aware of any federal requirement that says that if a patient requests a physician consult, that a physician has to respond. My understanding of the federal EMTALA regulations and interpretive guidelines is that it is correct that if the treating physician, or the emergency physician in this case, requests that a consulting physician appear at the bedside, that has to happen. However, the federal interpretive guidelines oftentimes change, and I can give you some examples of that if you'd like. And the other issue is that in the interpretive guidelines, it seems to imply that only at the time you actually make that phone call. So when I call up the orthopedist and they say, we would like a consultation, at that point, if they say, I'm going to have my PA come in, that we can decide that's okay. We would like it to be very clear that even if we say that's okay, and then later on we disagree with what's going on, that we should then be able to get the physician to come even at that point, even after the initial phone call is made. We can call them back and say, we need you to come to the bedside. And then the last problem is that California should have, in our opinion, and this is, I think, why 1317 exists, have its own way to enforce this requirement that all patients have access to medical screening examinations, emergency treatment, and consultation care, and should not rely upon the federal government's decision to either enforce or not enforce, or to change the guidelines in which the law is interpreted and then enforced.
Did you want to respond to that, Mr. Doherty?
Sure, briefly, without having to bring everybody through all the stakeholder meetings that we've had, just a couple things. The intent behind this bill is to allow other appropriate personnel pursuant to their scope of practice and licensure to provide treatment in the ER and consultative services in the ER that is absolutely consistent with federal EMTALA law. That's why in existing law it says, or to the extent permitted by applicable law. So whatever federal law requirements are is what the state requirement would be. We're just basically saying we're not intending to expand nor restrict anybody's ability to provide those non-MD services in the ER by way of this bill. The second piece on the consultation is we have taken language in the amendments that were recommended by the committee that the author has accepted that basically says a request for consultation shall be made by the treating physician and surgeon, which is the ER physician, or by other appropriate personnel acting pursuant to their scope of practice and licensure under the supervision of a physician and surgeon, provided the request is made with the contemporaneous approval of the treating physician and surgeon. The word contemporaneous is kind of a term of art that we've agreed upon, which basically says the consultation can't even be made by the non-MD provider unless the ER physician approves that consultation be made. That is now a state requirement for every single emergency department in the state that goes above and beyond anything required under existing law and goes above and beyond anything required under EMTALA. So I think we've gone kind of a long way to address that. In terms of physician assistant scope of practice, they have a legal document which is called the Delegation of Services Agreement. This legal document is intended to spell out the specific delegative authority and functions that
a physician assistant is to provide and those services that the physician assistant is not to provide. So that legal document allows that PA to act as an agent of that supervising physician. Those things, if you're practicing in the ER regularly, would stipulate what those conditions are, and that's consistent with their scope of practice. I understand nurse practitioners and some other folks have other sorts of legal documents that spell out that scope of practice. But that's what we're trying to do. I don't know if what we continue to discuss with the ER physicians is something that's really germane to this bill per se, or something that's another issue for another day.
Okay, thank you. Senator Pavley, I am going to support the bill. I appreciate you bringing it forward. Is there any other opposition? I'm sorry.
Pardon me. I'm Kelly Green with the California Nurses Association, regrettably opposed to the bill. We would echo the comments made by the emergency physicians with regard to the need to ensure that the standards of care are the highest possible, and for those reasons, with potential concerns about scope expansions with the bill, we must oppose at the time. Thank you.
Thank you. Is there anyone going to be making a motion?
I'll move it.
Okay, we have a motion by Senator Anderson. Is there any questions from the members?
Just a comment. I have serious concerns about the bill. I'd like to see, I know that, you're the kind of author that's going to keep working on this, but I don't like I'm concerned about the opposition. I think that they have valid arguments, so I really would like you to continue to work on this.
That's the intent as we move through the process. The scope of practice issue I thought was somewhat resolved, but obviously we need to again restate that and clarify it, and so I look forward to clearing up any of that ambiguity. I look forward to working with CNA. Some nurses or associations support it, some don't. I thank you, Chair Hernandez, for your assistance on this bill, and look forward to continuing to work and meet with all the stakeholders.
Again, let me reiterate, I appreciate everything you're doing for this bill. I will also offer my staff, if you would like us to continue to meet in our office to work out any differences to help you resolve any of Senator Woke's problems, but I'm here to support and help you, Senator.
Thank you very much.
Thank you. Okay, any other questions from the members? Seeing none, we do have a motion by Senator Anderson. We have a due pass as amended to appropriations. Secretary, please call the roll.
Senator Hernandez?
Aye.
Hernandez, aye. Strickland?
Aye.
Strickland, aye. Alquist? Anderson?
Aye.
Anderson, aye. Blakesley? Blakesley, aye. De Leon? DeSaulnier? Rubio? Wolk? Wolk, aye.
We do have 5. The bill passes. We will put this bill on call to allow members to add on. Senator Pavley, and I believe we're now back into the special order of business.
Thank you very much for letting me juggle that.
No problem. Thank you. We're now at SB 255, Pavley, healthcare coverage, breast cancer. Again, let me just reiterate, at this point, we're not going to be voting on this because without objection, the committee's action will be to hold this bill SB 255 with a future hearing to be set. We will keep these items open to allow for additional members who want to join us. I do appreciate it, Senator, and thank you very much.
Thank you very much for allowing me to present on this bill, and I'm hoping as we get some more clear signals from the federal government, we know the first 12, maybe next month or in the next few months. I think this is one of those issues that's going to be clearly spelled out that it is covered on existing health care policies and plans because it's a very important bill, especially to women who are facing breast cancer-related problems.
And I agree, Senator, and you have my commitment that as soon as we hear information, I will make it a point that we will work as soon as possible to resolve your issue and this issue. Thank you.
Senate Bill 255 is sponsored by the Susan B. Komen for the Cure Foundation, and I'm very honored to carry this bill on their behalf. It's their only bill of the year, and I think a very important one. And to me, it's just simply clearing up a problem with a definitional change that's needed in the law. Mastectomies and partial mastectomies are covered of their health insurance plans, and a lump lumpectomy needs to be spelled out and clarified that it is indeed fits in with that medical terminology. And it's very important as women are faced with lumpectomies that are now more complicated and expand into lymph nodes and et cetera, that there may be times on occasion that the patient and the doctor feels that a overnight stay or more treatment is needed. And that's what this is about, with 1 out of every 8 women now facing breast cancer sometime in their life. And on a personal level, had a grandmother that died. My mother's gone through it. It's an important issue, and there's no doubt in my mind that the federal government will be adding this to their list of coverage. In fact, as this has gone through the California Health Benefit Review Panel report called CHIPR, it states that this particular bill would have no measurable change in benefit coverage or cost, and no measurable change in total premiums and total health care expenditures are expected. And then it goes on to say the report also recognizes that the bill services are considered standard coverage likely to be included in the essential benefit package at the federal level and unlikely to place any additional fiscal liability to the state. That means no cost to the general fund. This bill simply clarifies that a lumpectomy is a medical term for partial removal of the breast, a description already included in definitions in the law. Mastectomies and lumpectomies are the 2 standard treatment options most likely recognized by medical authorities, as well as the state of California in its booklet given to all providers. I think this is an important measure to clarify with many women facing the consequences of not being able to work with their physician in the event that a lumpectomy becomes a little more challenging and there's problems with staph infections, bleeding, age of the patient, and a variety of other circumstances. So this is one of those mandate bills where there is no cost caught up in sort of red tape. And just to share with you a little of my frustration, today all the mandate bills are going out of the Assembly Health Committee, and I'm not sure how we're dealing with all that. But this bill, since it's covered by insurance policies in most all cases, virtually all cases, according to the Benefit Review Panel, will likely be part of the federal policy plan. And at the end of the day, will have no cost to our general fund.
Thank you, Senator.
I have some witnesses.
Yes, thank you. Proceed.
Good afternoon, Mr. Chair and members. Angela Blanchard here today as the sponsor of SB 255 on behalf of the California Collaborative of Susan G. Komen for the Cure. As Senator Pavley stated, we believe that SB 255 clarifies and updates medical terminology to ensure that the decision about when to leave the hospital after a mastectomy or lumpectomy is made by the patient and their provider. Since 1997, current law has allowed the length of a hospital stay associated with mastectomies and partial removal of the breast to be determined by the patient and their provider. SB 255 clarifies that partial mastectomies are included and that a lumpectomy is a medical term for partial removal of the breast. We look forward to working with you in the months ahead and strongly support the bill.
Thank you. Next.
Good afternoon, Chairman and the members. My name is Heidi Suverville, and I am the Vice Chair of the Susan G. Komen California Collaborative for Public Policy that represents the 7 affiliates of our state. I also serve as a patient navigator, a community health supervisor of breast cancer patients at the UC Davis Cancer Center. I also have a very personal history with this, as every single woman for 4 generations in my family has had breast cancer. And I, too, have made a promise, just like the Susan G. Komen Foundation, to my 3-year-old daughter that I promise to do everything I can to help in this disease before she must deal with it. From a personal and professional perspective, I have witnessed every type of breast cancer surgery that you can have, everything from a bilateral mastectomy to a lumpectomy with sentinel node removal. As early detection has definitely increased our chances of fighting the disease more effectively and finding cancers earlier, it has also increased the likelihood that more women are going to be offered breast conservation surgeries, as we call them. Breast conservation surgeries can entail anything from lumpectomies to partial mastectomies, and I want to urge you to support SB 255 because this is not a mandate. This is just a clarification of medical terminology. Current law states that it will cover for partial mastectomies, and a lumpectomy is a form of partial mastectomy. We just want to be clear on that. SB 255 is also cost-effective, as it is far less costly to have a patient stay overnight than it is for them to come back 2 days later with a staph infection and admitted through the ER. I also am here representing our surgical team at UC Davis Cancer Center. Our surgical oncology team wished that they could be here today, but unfortunately the doctor who was supposed to testify today is actually in an emergency breast cancer surgery. And to them, this bill was a no-brainer. In fact, they were quite appalled that a lumpectomy wouldn't be considered under the law. And they do hope that this is considered and urged and passed through. You should all have received a copy of a letter that our surgical oncology team has written to all of you, urging the passage of this, as they have said that basically the evolution of breast cancer surgery has evolved to where we are doing more now with less invasive procedures, but just because they are less invasive does not mean that they have less complications. I can tell you that a woman, if she has a mastectomy versus a lumpectomy, on the day of surgery, the day that supposedly some of these outpatient procedures are having women sent home, on that day, there is no difference between their range of motion and their affected arm. There's no difference in their sense of devastation and loss, and there's no difference in their chance of infection. So whether it's a mastectomy or a lumpectomy, it makes no difference. The risks are still there. They're still the same on that day one after surgery. So please, I humbly ask you to please pass and move this bill.
Thank you. Next.
Good afternoon, Mr. Chairman and members. My name is Marianne Rogozinski, and 6 years ago I was diagnosed with breast cancer. I went in for my annual mammogram, and they notified me right away that I had a lump, and they immediately scheduled me for a biopsy. Initially, I was told by my primary physician that I would have a lumpectomy and radiation. Unfortunately, when I met with my radiation doctor, I was informed that I would also have to have chemotherapy. At first, I was shocked and distressed. I wanted to know why. He told me that part of my tumor was a little bit wider than I like to see in stage 1, and so this white spot in the tumor moved me to stage 2. Therefore, chemo was recommended. My initial reaction was, well, let's get on with it so that I can get on with my life and my family could get on with their lives.
Thank you very much. Next.
Alicia, is it? Sorry. Okay. Alicia Sanchez with the American Cancer Society in support.
Thank you.
Donna Brownsley on behalf of the Breast Cancer Fund in support.
Thank you. Thank you very much. Anybody else in support? Is there anyone in opposition? Are you in opposition coming up? Okay.
Thank you, Mr. Chair and members. Nick Luizos on behalf of the California Association of Health Plans in very respectful opposition to 255. We do appreciate and understand what the intent of this bill is, and we do not dispute how vital it is to deliver appropriate services to women with breast cancer. Indeed, under existing law, health plans are already required to cover a wide variety of cancer-related screening and diagnosis and treatment. We do believe, however, that policymakers should wait to review the federal government's pending guidance on what the essential benefits will be in the new insurance exchange that's been established in California. As the committee is aware, the federal government will be subsidizing care through the exchange. In an effort to manage the subsidy costs, the federal government will be defining a list of essential benefits that it will pay for, and clearly states that states will be on the hook for any benefits that it mandates beyond that. I will just add very briefly that California already has 45 benefit mandates on the books that impact Knox-Keene licensed health plans. There are 49 mandates if you include the PPOs. We understand the costs associated with individual mandate proposals can vary. However, many of the newly proposed or existing mandates that are currently in existing law may not be a part of the essential benefits package when that is released by the federal government. We would just state that we believe it's wise for policymakers to wait until that guidance comes out. You can enact a bill. You may have to revise it later. It's probably best for the legislature to wait to review that guidance to make sure there's no conflict. Thank you.
Thank you. Next.
Stephanie Watkins on behalf of the Association of California Life and Health Insurance Companies. We too understand the intent of this bill and sympathize with it. In order to be brief, I'd just like to reiterate the comments made by CAP as well, and that we are also in opposition to the bill.
Thank you very much. Thank you, Senator. And I'll just, in response to one of your comments, your opening statements, with regard to the Assembly bills that have moved out of committee, we will be treating those in the event, if they come over here, the exact same way. I will make my highest priorities once we reconcile all of the essential medical benefits, that I will make sure that we take care of yours as soon as we can. Thank you.
Thank you.
And please close.
Yes, thank you very much. I just wanted to just sort of reiterate, and I understand what you're saying. There'll be consequences between the two houses, but the opposition here was interesting, and it was sort of a generic opposition to all mandate bills. And that was sort of interesting because in the California Health Benefits Review Panel report, they say specifically virtually all employers provide coverage for lumpectomy services. The report states that lumpectomy services defined in SB 255 are considered standard coverage for employer-based plans, which is the National Labor Survey's criteria for inclusion. It just hasn't been added yet to the 12 and could be momentarily. This is a no-cost, and I agree with the oncologist from Davis, a no-brainer issue, and on behalf of women facing very difficult decisions and with their doctor, I respectfully ask for your aye vote as soon as we can hear this bill.
Thank you very much, Senator, and I appreciate. The next order of business is going to be item number 6, Special Order SB 166, Steinberg, healthcare coverage, mental illness, autism spectrum. Again, without objection, the committee's action will be to hold this bill, make it a 2-year bill. Senator Steinberg and I had a lengthy discussion before we made the decision to hold all mandate bills, but I do appreciate it and offer you that you move forward so that we can at least present the bill, hear it on the merits, and thank you, Senator Steinberg.
Thank you very much, Mr. Chairman, for your hard work, and as you just mentioned, even though it is my bill, I agree with the chair's recommendation and direction that it is important that we look at the final result of federal health care reform, the definition of essential medical benefits, and the potential general fund impact of this bill. Having said it, I just want to be clear publicly, state publicly, because there are a lot of great advocates here and people who spend their life trying to improve the lives of kids that I am committed over this 2-year session to make what is the sum and substance of this bill happen. Maybe it'll happen through the federal government. We got to go back to D.C. and work to try to make that happen. But one way or another, I'm committed to successful resolution of this issue. So what is this? This is a bill that would mandate behavioral intervention therapy. It is a recognized form of healthcare therapy by the nationally renowned UC Davis Mind Institute, the United States Surgeon General, the National Institute of Mental Health, and the U.S. Agency for Healthcare Quality and Research, and the American Academy of Pediatrics. In autism, there is better brain function with this proven therapy, behavioral intervention therapy. The results include improved speech and language, a higher IQ, better cognitive function, and reduced self-injurious behaviors. Now, the health plans have argued that this is educational and not medical, and I disagree. Doctors and experts say that behavioral therapy is the single best form of health care treatment for autism. The bill itself only requires treatment programs that are scientifically validated and have demonstrated clinical, emphasis on clinical, medical efficacy. The bill allows health plans to use the independent medical review, the standard form for arbitrating coverage disputes, to exclude any treatments or interventions that are either experimental or not medically necessary. The bill also ensures that the decisions, the medical decisions about autism therapy, remain where they belong, in the hands of doctors, with the input of families and other licensed healthcare professionals. Now, many of you on the committee and members of the public know that the autism advocacy community is a force, and a force for good. They're breaking ground everywhere, because we know that this malady, whatever you want to call it, this disability, autism, is increasing and it is growing. And you talk about your proverbial spend a little bit now to save a lot later and create better life outcomes for people. This is something that we have to do. Not now, for the reasons that the chair has appropriately, I think, outlined. But we've got to get this done. I'll turn it over to the chair, of course, and the members and the advocates. Thank you.
Thank you. Anyone like to speak in support of the measure? Please state your name.
Yes, good afternoon. My name is Ariva Martin, and I am an attorney, and I am a mother of a son who is on the autism spectrum. I'm also the co-founder and president of Special Needs Network, and I'm here in support of Senate Bill 166. As the president of Special Needs Network, I represent thousands of families in Los Angeles, primarily working-class families and families that live in underserved communities. These families have very limited access to intervention services that they desperately need. We've submitted testimony from hundreds of these families that talk about the inequities and the struggles that they face in trying to get care for their children. These families need the help that this bill can provide. Families in making an effort to seek behavioral therapy for their kids have met with two obstacles. First, they were told that behavioral therapy is experimental and not medically necessary. Recently, there have been changes that have occurred, and the therapies are being recognized as medically necessary. But the health plans decided, you know, since we have the evidence now that the services are medically necessary, that the services aren't covered. They're not a covered benefit. And by making the determination that they're not a covered benefit, the doctors, the medical providers, the people that really know what these kids need are no longer involved in the decision-making process. This isn't direct contravention of AB 88. We have mental health parity in the state of California. That law provides that autism care and treatment should be provided, but families aren't afforded an opportunity to get that care. SB 166 closes that loophole. It closes the gap. It provides families with the services they need for kids. We know that when kids get behavior therapy in the early intervention stages, 2 years old, 3 years old, 4 years old, we can make a tremendous difference in their lives. We can see kids have improved functioning from language and speech to social skills. We urge the Senate Health Committee to vote in favor of SB 166 to provide families with the care that they desperately need. And I just want to make a final point about families in underserved communities. African American and Latino families often face the biggest challenges in getting care for kids with autism. They are diagnosed 2 to 4 years later than their typical peers, and once diagnosed, getting intervention services is extremely difficult. SB 166 will also remove yet another impediment that these families, many of whom who live in underserved communities, face. And so again, on behalf of Special Needs Network, all the families that I represent in underserved communities, and on behalf of my own family who struggled to get health care for my own son, I ask for a vote in favor of SB 166.
Thank you. Next.
Hi, my name is Kristen Jacobson, and I'm testifying on behalf of the bill sponsor, the Alliance of California Autism Organizations. My 3-year-old son is in desperate need of behavioral intervention therapy for his self-injurious behaviors, aggression, and bolting into traffic. But I'm going to talk about the economic impact of SB 166. While the cost is astronomical for a family to pay for this treatment, when spread across the risk pool, the economic impact is incredibly minimal and far below the expectation of any state that has passed this type of insurance reform. Now, 25 states around the country have passed similar legislation, and there is significant actual cost data about what it costs. South Carolina's cost is 45 cents per member per month. Blue Cross Blue Shield of Minnesota, it costs about 80 cents per member per month. And all of these figures are actually significantly less than what the CHBRB estimate is. But I do want to talk about the general fund because, of course, there are some impacts of SB 166 on the general fund, but the net impact is a savings and a significant one. There is a minimal cost impact to Mr. MIB and to CalPERS and zero cost to Medi-Cal. The total cost is approximately $18 million to the general fund. On the other hand, the savings is about $100 million, and that's a huge difference. Today, our taxpayers through the regional centers and school districts actually pay for this health care treatment. The Department of Developmental Services spends $320 million every year on all behavior intervention services, much of which is for autism. CHBRB itself actually estimates an offset of $146 million from SB 166, the vast majority of which would expect it to be DDS and CDE. Even if only 50 to 80% of this offset is general fund savings, that's $50 to $100 million net savings annually after all costs. Families like myself, we pay premiums to our health plans, but the plans are shifting this cost to the state, and the taxpayers right now are paying the cost of this health care. Regional centers are supposed to be the payer of last resort, but for autism, they are frequently the payer of first resort. I know you may be frequently told about potential long-term savings that are maybe considered speculative. While there are significant long-term savings associated with this bill for welfare, et cetera, in the magnitude of billions, the savings that I'm talking about, the $50 to $100 million, is year one, day one savings. If I go to my health plan and I ask for treatment to be covered, within 5 days I will have an answer, and then the state can stop paying for it. And if the answer is yes, the state will be able to stop paying for the health care. The high-cost option is to do nothing. And in this budget crisis, we cannot afford to do nothing. Even if we have state costs just for a few years, state savings, it would be important. Not only is this bill a moral imperative, it's a fiscal imperative. Given our state's budget, I urge your support of this bill. The good news for my son is that the ABA is working. His self-injury is down, almost non-existent. Bolting is gone. Aggression is significantly down. But this is not thanks to my health plan, to whom I've paid premiums for years.
Thank you. Next.
Thank you, Mr. Chairman, members of the committee. My name is Lori Unum. I'm a lawyer and the mother of a child with autism. I'm also senior policy advisor and counsel with Autism Speaks, the world's largest research and advocacy organization on behalf of families with autism. And I teach a law school class called Autism and the Law. I've been asked to address today the interrelationship between this bill and federal health care reform. As has been much discussed this afternoon, states are on the hook for any benefits that are mandated by the state that exceed the essential benefits specified in the PPACA. If you'll take a look at this handout that I think you all have before you, you will see that the benefit for which we seek coverage in this bill is included in the essential benefits package. If you look at page 3 of the handout, this is a list of the essential benefits. There are 10 essential benefits. This is what the list looked like in 2009 when the predecessor bill to the PPACA was making its way through Congress. Autism Speaks went to Congress with an amendment. And if you look at the next page, you can see what that amendment was. We wanted to make sure that our specific benefits, behavioral intervention therapy, were included in the essential benefits package. We went to Congress with an amendment that added to the benefit mental health and substance use disorder services, comma, including behavioral health treatments. So if you look at the next page, page 5, you can see the list of essential benefits as it passed. It is the same 10 essential benefits that existed in the bill in 2009, but with one addition, the amendment that Autism Speaks pushed, comma, including behavioral health treatment. Now, you might argue that, well, we're not sure exactly what that means. I would give anything if I had a video in 4 minutes to show you right now the C-SPAN footage of when that amendment was introduced. It is very clear and very explicit that the purpose of that amendment and of the term behavioral health treatment is to cover behavioral intervention therapies for individuals with autism. So we're certain that it's going to be in there, that it is in there. Further, as Kristen mentioned, 25 states have now passed legislation requiring coverage for behavioral intervention therapy, and a dozen more states are poised to pass legislation in the near future. So when the Department of Health and Human Services at the federal level surveys the national landscape to make sure that this is what is meant by behavioral health treatment, they will see that it is. Finally, I'd just like to point out on the very next page of the packet, this is a map that we keep at Autism Speaks. We turn a state green on our map when they enact autism insurance reform that requires coverage for behavioral intervention therapy. You can see the 25 states. Really, I've kind of cheated. Virginia is already green, and their bill will not become law until May 6th. But so there are 26 states turned green here. If you look at the list at the bottom, starting with 2010, you can see 11 legislatures that have passed this benefit, have mandated this benefit since March of 2010 when the federal health care legislation passed. So many, many legislatures are certain that behavioral intervention therapy is in the essential benefits package. So we strongly support SB 166, and we urge your passage at the earliest possible time.
Thank you. Next.
Donna Seitz, representing the Los Angeles County Board of Supervisors. We are in support of the bill for the reasons that have already been stated.
Thank you. Next.
Hi, John Mathias. I'm a volunteer leader at 6 autism organizations in Northern California. All those organizations strongly support the bill. I also have a letter of support from 1,300 families in Southern California who are not able to come up today to testify.
Thank you very much. Next.
Mr. Chairman and members, Rick Rollins. I'm here in 2 capacities. First, representing ARCA, the Association of Regional Center Agencies, which is in strong support of this bill. We also believe that the benefit of the enactment of this bill will save the taxpayers and the state budget millions and millions of dollars of taxpayer dollars that are currently going to pay for this service. And primarily, I'm here on behalf of my son, Russell, who graced the cover of Newsweek magazine a few years ago. I'm a co-founder of the UC Davis Mind Institute and a number of other autism advocacy organizations. And this bill, Mr. Chairman, first I want to also thank you personally for your commitment to our community. Your service in the Assembly has been exemplary in supporting efforts for our community. But this legislation, I just want to tell you, is the single most important piece of legislation that the autism community has been involved with since the enactment of the legislation creating the Mind Institute itself. This is Autism Awareness Month nationwide and worldwide. That started here in California in 1993, and I think it's very appropriate that you're considering this legislation at this time.
Thank you very much. Let me also just comment on the first, well, everybody, but the first 3 presenters. You did an excellent job. I was very, very impressed. It's obviously a very, very important issue, not only to you, but to everyone. If you don't mind, I know there's quite a few people who like to come up. What I'd like to just ask is anyone who does come up, if they can just say they support the bill and just state their name, just so that we can make sure that we get everyone enough time to get through. So just name and your position, please.
I'm Jim Lantry. I represent the DIR Floor Time Coalition of California. That's over 1,000 children with autism, their parents and treatment providers that are providing treatment with the DIR Floor Time model. We are in full support of this bill. Thank you.
Thank you.
Is the
please say yes. SB 166.
Thank you. You did a great job.
My name is Karina Morales. I'm a single mother of 4. I drive all night from Orange County with my son, David. He's 12 years old. I fight a lot to find ABA's, the behavioral service, but we can, regional center say it's educational problem, school say it's regional center, nobody can until I get an attorney. I got the service, he's 3 years old, but he can, before 3 years old, he was jumping everywhere. Right now you can see he was since 1:30 here, sitting down, quiet, playing his DS. The behaviors are down. He doesn't talk, he know my name when he was 8 years old. He used diaper until 5 years, until when he was 5 years old. This is a treatment for autism. Please help us.
Thank you. Thank you very much.
Say yes on A.
Thank you.
SB 166.
No.
Hi, my name is Gloria Hernandez, and we have a support group for autistic kids. We have 12 years with this support group in Orange County, and we come every time when it's possible for us. It's coming to drive. And we support, my son is autistic. He's 15 years old, and he has ABA. It's different than life my family, and we are support SB 166.
Thank you very much. Next.
My name is Hilda Cuenca, and my son has 12 years old. He's nonverbal autism, and I'm coming from Orange County.
Thank you very much.
And
Next.
I support SB.
Thank you.
My name is Griselda Gonzalez. I'm coming from Orange County. I really support SB 166.
Thank you.
Hi, my name is Socorro Valdivia, and I support SB 166. And my daughter's name is Kaylin. She's autistic. She's 9 years old, and I support this because she really needs help, and then that's why I'm here to
Right.
asking you for help.
Thank you.
So
Thank you. Thank you. We can just name and position, please. Thank you.
Teresa Anderson with the ARC of California, and we are in support of the bill.
Thank you very much.
Rhonda Ransdell, a parent of a 13-year-old daughter with autism, strong support of the bill.
Thank you.
Child. I'm a parent of a child with autism, and I ask you to please support this bill.
Thank you.
Well, my name is Sam Wergler. I am autistic, and I strongly support SB 166.
I'm Owen Wergler, and I strongly support SB 166.
Thank you.
I'm Deb Wergler, Sam and Owen's mom, and I strongly support SB 166.
Thank you.
Laura Wasco on behalf of the California Association of School Psychologists, strongly in support of 166.
Thank you.
Erica Hoffman on behalf of the California School Boards Association, the Coalition for Special Education, and the statewide SELPA directors, all in support of the measure. Thank you.
Thank you. Anyone in opposition?
Good afternoon, Chair and members. Charles Bakke with the California Association of Health Plans. Just first, I'd like to acknowledge, the commitment that the author and his staff have given to this issue over the last few years and the work of their task force, and also acknowledge all the parents who are trying to do the best they can with difficult times, both with state funding and in their own pocketbooks to pay for these services. As we've mentioned in our ongoing discussions with the author, we unfortunately do have to oppose SB 166 because we believe that the bill inappropriately shifts the cost of educational, life skills training, and other non-medical services for children with autism to employers and individuals purchasing health care coverage. These services have been historically and appropriately provided through schools and regional centers to those living with ASD. An independent analysis of this bill by the California Health Benefits Review Program estimates that premiums and out-of-pocket costs would increase for Californians by over $200 million. I also wanted to just clarify that health plans do cover medical services for children with autism. We cover early childhood screening, diagnosis, assessment, medication, speech, physical, and occupational therapy, as well as psychotherapy. The controversy in this bill is over the services that are labeled by SB 166 as behavioral intervention therapies. And we just disagree. We do not believe that they are medical services. In fact, the American Academy of Pediatrics labels the main service mandated in this bill, ABA, as an educational service. Now, as mentioned in earlier testimony, federal law does put the cost of benefit mandates on states if they exceed the essential benefits. I wanted to point out that the California Health Benefits Review Analysis points out in looking at this bill, and I'll quote from their analysis, it's unclear whether there will be differences between the mental health and rehabilitative, habilitative benefits included in the essential benefits and the benefits required in SB 166. So we believe it's important that the pending federal definitions come out. Otherwise, health plans under the terms of this bill would be required to provide coverage for these services in 2012 and 2013 and would have to turn them off in 2014. We think that would cause considerable confusion. So again, thank you very much for taking our testimony, but we must be here in opposition respectfully to SB 166. Thank you.
Next.
Mr. Chair and members, Stephanie Watkins on behalf of the Association of California Life and Health Insurance Companies. While we sincerely sympathize with the goal of the bill, we regrettably have to oppose it for all the reasons already stated.
Thank you. Thank you. I appreciate everyone's testimony. We're going to now move on to the next item.
Thank you very much. Senator Steinberg also asked me to convey his appreciation for the work of your staff, so thank you.
Thank you. Okay, we're going to do item number 11, SB 256, Strickland, Medi-Cal, California Medical Assistance Commission. Senator Strickland.
Thank you, Mr. Chair. Members, SB 256 would eliminate the California Medical Assistance Commission, otherwise known as CMAC, and transfer its powers and duties to the Department of Health Care Services. The results achieved by CMAC, Administered Selected Provider Contracting Program, are not in dispute, but the continued need for the Commission is. The functions of CMAC have greatly diminished over the years, and with the adoption of a new rate-setting methodology, it is unclear why the duties of CMAC cannot be shifted to the Department. I'm willing to accept the amendments to address the issues raised in the analysis regarding the effective date of the bill and transfer of employees, and with that, I ask for your aye vote.
Does anyone like to speak in support of the measure? Is there anyone in opposition? Is there any questions? We have a motion to move the bill by Senator Blakesley. Just real quick comments. I understand your arguments, however, but there are some issues with the timing of the measure in its current form, and CMAC staff has demonstrated track record of saving the state money, and hospital negotiations will continue at least until we have implemented the DRGs. So under this bill, we are transferring the CMAC's duties without transferring the staff, so I have a concern there as well. So,
and I'm willing to take that amendment to transfer the employees. as well as the effective date.
Right. But I think at this time, I'm not prepared to support the measures, so I'm going to ask for a no vote.
Okay.
But Secretary, call the roll, and we have do pass as amended to appropriations.
Senator Hernandez?
No.
Hernandez, no. Strickland?
Aye.
Strickland, aye. Alquist? Alquist, no. Anderson? Blakesley? Blakesley, aye. De Leon? DeSaulnier? Rubio? Wolk? Wolk, no. Okay, we've got 3 to 2.
We have
2 yes.
we have 2 yes and 3 no's. We'll put that bill on call. Senator Liu? Good afternoon.
Good afternoon.
And we're item number 14, SB 757, Liu, discrimination. Good afternoon and welcome.
Thank you. Thank you, Mr. Chair and Senators. First, I'd like to take the amendments discussed in committee analysis for the next policy committee. And thank you for the committee staff and the chair for all their work on this bill. Under existing law, insurers are required to provide the same coverage to domestic partners that they provide to a spouse. Unfortunately, some out-of-state insurers are able to use a loophole to avoid providing these benefits. This bill would simply close this loophole by requiring any health insurance policy issued to someone in California to be subject to the state's requirements for equal coverage. The bill not only ends this discriminatory practice, but also ensures a level playing field for California's own licensed insurers. Respect request an aye vote, and I have a witness here in support.
Thank you very much.
Hi, Matthew Bunch on behalf of people. Matthew Bunch here on behalf of Equality California. We're proud to be the sponsors of this bill.
Thank you. Anyone else in support? Is there any opposition? Any questions from any of the members? Do I have a motion? We have a motion by Senator Alquist. I will be supporting the bill. I'm going to ask the Secretary in a minute just to call the roll, but just let me clarify that the amendments that you will be taking to Judiciary, is that correct?
Correct.
Okay. And that so this is due pass to Judiciary. Secretary, call the roll.
Senator Hernandez?
Aye.
Hernandez, aye. Strickland?
No.
Strickland, no. Alquist? Aye. Alquist, aye. Anderson? Blakesley? De Leon? DeSaulnier? Rubio?
Aye.
Rubio, aye. Wolk?
Aye.
Wolk, aye.
We have 4 yes and 1 no. We'll put that bill in call. I'm going to now turn the gavel over to my Vice Chair. The last 2 bills are my bills.
Members, file item number 3, SB 135 by the chair. Chairman, you may open.
Thank you, Mr. Chair and members. First, I'd like to thank committee staff for their hard work on this bill. They've done a great job. They've reviewed the amendments in the analysis and will definitely be taking them. This bill would allow a licensed and certified hospice program to operate an inpatient facility within a hospice license. Presently, hospice providers who wish to provide inpatient hospice directly must be licensed as something else, a congregative living health facility, a skilled nursing facility, or a specialty hospice, none of which are entirely consistent with the provision of hospice care. If the hospice is providing care in another health or residential care facility, this program can only provide hospice services and may not provide any other services to the patient. This makes the hospice dependent on the health or residential facility for much of the patient's care. This can lead to discontinuity of care in some cases. This bill does not change these available options, but simply adds another option by establishing a new category of hospice facility. Hospice programs will be able to operate their own facility with standards that are tailored to hospice care, and which results in continuity of care that is consistent with the patient's last wishes and appropriate for the end-of-life care. It also does home-like environment that permits visitors at any time of the day, a safe environment for those who may not have family or friends to provide care, and the opportunity for a patient to stay in the residential community if they live in a residential care setting. I have with me individuals who like to speak in support of the measure, and I respectfully ask for your aye vote, Mr. Chair and members.
Witnesses in support.
Peter Kellis on behalf of the California Hospice and Palliative Care Association in support of the bill. We have been working with those who have had concerns with the bill, are accepting a number of amendments. As mentioned by the author. Given that there are still some arguments in opposition, I would briefly address those and then turn it over to the other witnesses. With regard to the questioning of whether or not there is a necessity for this legislation, I would just like to highlight there are roughly 300 hospice programs in California. And there are less than 15 sites that are providing hospice care in the current facilities that are eligible in California. So if there was not an impediment to doing so, hospices would be doing this already. The fact is that they're not. There is an impediment, and that impediment is that every facility in California is currently regulated to keep patients alive or to rehabilitate them. Hospice care is about palliative care. It is about to ease the state, the passage of dying, and for that reason, the regulatory construct simply does not work under current law, which this bill would address. Secondly, we are willing to take some amendments that would ensure that there is adequate staffing available to the patients of the hospices that would be eligible under this program. Currently, when a patient selects hospice, they waive curative care. They receive only palliative care. No matter where the setting is, whether it be the home, skilled nursing, hospital, in a licensed facility that would be rated by this legislation, each patient still would get assigned to a medical doctor, an RN, a social worker, whoever within the hospice team provides care to the patient. That would be unchanged under this legislation. Happy to continue working with those who are invested in this issue and would appreciate support.
Further witnesses?
I'm sorry.
No, go ahead.
Hello, I'm Holly Swiger, and I am a registered nurse that's been with hospice for 27 years, and I'm here representing the California Hospice and Palliative Care Association in support of SB 135. And I just want to say that this bill provides a way to assure the right focus of care delivered by the most qualified staff in the safest and most home-like environment. And I'm here to answer any questions.
Thank you.
Jordan Lindsay with the California Association for Health Services at Home in support of the bill.
Thank you. Staff. Further witnesses in support?
Thank you, Mr. Chairman. Tom Sheehy, Greenberg Choreg, on behalf of the Visiting Nurse and Hospice Care Santa Barbara in support of this measure.
Thank you. Further witnesses in support? Witnesses opposition.
Thank you. I'm Kelly Green. I'm here with the California Nurses Association. And first, would also like to thank the committee staff and the author for a thorough analysis of the bill and for giving us an opportunity to express our concerns. Regrettably, the amendments that were recently put into the bill and that are being proposed in the analysis, unfortunately, do not fully address our concerns with the bill. And I'd just briefly like to quickly reiterate what those concerns are. With regard to staffing, we do not believe that the staffing standards provided in the bill provide for the optimal level of care for hospice patients when needed. Under the bill, a licensed vocational nurse could be the sole nurse on duty. LVNs do not have the scope training to do patient assessments, and our basic argument here is that when you have a facility of patients, even though these are hospice patients, they do forego curative care, but their palliative care needs and their needs as a terminally ill individual are complex. And what we want to ensure is that if you have patients in the facility at a time when we don't have at a time when their acuity changes and there is a need immediately for an assessment of that patient, potential changes to their pain management or to whatever course of care that they're on, that there is adequate staff there. An LVN is not adequate to provide to be able to respond to those on an immediate basis. The federal regulations that are cited in the bill do require a registered nurse on duty when there is at least one patient that requires general inpatient care. That doesn't address the situations where there are no patients, no GIP patients in the facility. And further, it also doesn't address the number of patients that could potentially be assigned to a nurse. So, for example, you could have a facility with 24 beds, and let's say 10 or 12 of those patients are GIP. The federal regulations only require to have one nurse on duty. So we do think that staffing is something that does need to be more thoroughly thought out with regards to if we're going to create a licensing category for a new healthcare facility, we want to make sure that the patients in there have access to adequate levels of care on a 24-hour basis. We also have concerns with regard to building standards. The bed limit that was recently amended into the bill does touch on this concern, but for our organization, it is still challenging to conceive a 24-bed facility to be genuinely considered as a residential facility. We think that the facility, which will house terminally ill, some of whom are going to have high acuity levels, we do believe that it's of utmost importance that the lawmakers apply appropriate building standards that are going to ensure safety of those patients and the staff within, and thus we believe that the OSHPD standards should be applied here and that they should be responsible for overseeing the hospice facility construction and renovation. And the last point is with regard to regulations, and we do appreciate the amendments that would put a deadline for regulations here. As we have stated, we do not believe that the conditions of participation are thorough enough in this regard, and regrettably, we would like to see regulations required immediately so that the process can get underway. We do know that it is often a lengthy process for regulations, and thus we would like to see that timeline reduced and have requirements, regulatory requirements imposed immediately. I'll just close by noting that the points of opposition to this bill are the same points that we raised last year with AB 50. While the most recent amendments in print do touch on some of our issues, they don't get to the heart of our opposition still, and therefore we must continue to remain opposed to the bill.
Any questions from the members? Yes. Senator Aquas.
I'd like to thank Senator Hernandez and the Hospice Association for thoroughly really looking at this issue. I think with the aging of the baby boomer, we certainly are going to have a lot more hospice facilities. And I think the 8 meaningful amendments, Senator Hernandez, that you've taken go a long way, and I'm very supportive of the bill. Now with the amendments, we're dealing with patient rights, information to patients, penalties, licensing, inspections, availability of care, deadlines for regulations. Also saying that the same penalties that apply to congregate living health facilities for violations will apply to the hospice facilities, which is also very important. I'd be happy to move the bill.
Thank you. The bill's been moved to do pass as amended to approach. If I can, Mr. Chair, I would like to add on as a co-author as well. Any other questions? Without that, Secretary, please call the roll.
Senator Hernandez?
Aye.
Hernandez, aye. Strickland? Strickland, aye. Ahlquist?
Aye.
Ahlquist, aye. Anderson? Blakesley? Aye. Blakesley, aye. DeLeon? Aye. DeLeon, aye. DeSaulnier? DeSaulnier, aye. Rubio? Wolk? Wolk, aye.
The bill has 7 votes. Bill's passed. Remains on call until the end of the hearing. Next, we have, Mr. Chair, file item 13, SB 677. You may open.
Thank you, Mr. Chair and members. This bill implements a requirement in federal health care reform related to Medi-Cal eligibility. This bill does 2 things. First, it conforms state law to federal law by prohibiting an asset test in Medi-Cal. When people apply for Medi-Cal today, the application asks for assets such as court-ordered settlements, life insurance, stocks, bonds, and money and savings and checking accounts. After 2014, federal law will prohibit states from using this test in Medi-Cal except for certain groups. This bill would make this conforming change to state law. Second, the bill implements a requirement in federal health care reform for Medi-Cal that states determine income eligibility and family size using the modified adjusted gross income, or MAGI, and is based on adjusted gross income and is currently used for tax purposes. I respectfully ask for your aye vote, Mr. Chair and members.
Thank you. Witnesses in support?
Mr. Chair and members, Elizabeth Landsberg with the Western Center on Law and Poverty here in support of this bill to conform the Medi-Cal eligibility rules to the Affordable Care Act. People often complain that Medi-Cal is complicated. Well, it's complicated because we've made it complicated, and so we look forward to simplifying, moving away from the current welfare-based income counting rules to these tax-based income counting rules, using a gross income test and eliminating assets test, which has been shown not to effectively keep folks off. Very low-income people don't have a lot of assets, so this will really simplify and streamline the program, and we encourage your aye vote. Thank you.
Further witness support?
Beth Capel on behalf of Health Access California in support of the measure. For the first several years that federal health reform is in effect, the federal government will pay 100% of the cost of the Medi-Cal expansion for the newly eligible population. That will then phase down so that eventually they're only paying 90%. Still a pretty good deal for the state of California. We think that getting several million more people insured through Medi-Cal is an important step forward. Thank you.
Thank you. Further
Chad
witness?
Silva on behalf of Latino Coalition for Healthy California in support of the bill.
Thank you.
Judith Regal with the County Health Executives Association, also today on behalf of the County Welfare Directors Association and the California State Association of Counties. We are supporting concept on this bill. We have always supported simplification of the medical eligibility process and think this is an important bill to move forward the federal requirements. We did just want to note that we do anticipate additional federal guidance coming down on these areas, which will inform how we need to move forward in California.
Thank you.
Allison Ramey on behalf of the California Primary Care Association, representing over 800 nonprofit community clinics and health centers currently serving over 1.5 million Medi-Cal patients. We are in support.
Thank you. Any witnesses in opposition? Any questions from the members? Bill's been moved by Senator Wolk. Mr. Chair, would you like to close?
Ask for your aye vote.
Please call the roll.
The motion is due pass to appropriations. Senator Hernandez?
Aye.
Hernandez, aye. Strickland? Strickland, no. Alquist? Alquist, aye. Anderson? Anderson, no. Blakesley? Blakesley, no. De Leon?
Aye.
De Leon, aye. DeSaulnier? DeSaulnier, aye. Rubio? Wolk? Wolk, aye.
That bill is 5-3. The bill passes. We're going to, we'll leave that on call because I believe Senator Rubio will want to add on later. Let's start off and go through all the file items, starting with number 1. The current vote for SB 51, Alquist, is 3-3. Call the absent members.
Senator De Leon?
Aye.
De Leon, aye. DeSaulnier?
Aye.
DeSaulnier, aye. Rubio?
That bill is 5-3. The bill passes. We will still put that bill in call so that Senator Rubio could add on. Next bill is item number 2, SB 63, Price. This was a bill that we didn't have a quorum yet. I would request that someone make a motion, moved by Senator Wolk. This is due pass to rules. Please call the roll.
Senator Hernandez?
Aye.
Hernandez, aye. Strickland? Strickland, aye. Alquist? Alquist, aye. Anderson?
No.
Anderson, no. Blakesley?
Aye. Sorry, this is number 2. Price?
This is number 2, Price.
Anderson, no. Okay. Blakesley?
Aye.
Blakesley, aye. De Leon?
Aye.
De Leon, aye. DeSaulnier?
Aye.
DeSaulnier, aye. Rubio? Wolk? Wolk, aye.
That has 7-1. The bill passes. We'll go ahead and put that back on call so that Senator Rubio can add on when he gets back. We're down to item number 3, SB 135, Hospice Facility. The current vote is 7-0 as amended. Call the absent members.
Senator Anderson. Senator Rubio.
This is item number 3, SB 135, Hernandez Hospice Facilities. Aye.
Anderson, aye.
We have 8-0. The bill passes. We'll allow Senator Rubio to add on. This is SB 155, Evans, due pass as amended to appropriations. The current vote count is 4-1. Call the absent members.
Senator Strickland. Blakesley.
This is
SB 150.
SB 155, item number 5. Okay, go ahead.
Okay. De Leon.
Aye.
De Leon, aye. Desaulnier.
Aye.
Desaulnier, aye.
Blakesley, aye.
Blakesley, aye. Senator Rubio.
Oh, you already voted. You already voted. That has 7-1. The bill passes. All the members are present. That bill is out. We're in item number 7, special order of business, SB 173, Semidian, due pass as amended to appropriations. Currently has 5-0. Call the absent members.
Senator Anderson. No. Anderson, no. Blakesley. Aye. Blakesley, aye. Desaulnier. Aye. Desaulnier, aye. Rubio.
That has 7-1. All the members are present. The bill passes. That bill is out. What's the file item? Okay, we have file item number 8, SB 222, Allquist Health Plans Joint Ventures. It's due pass to appropriations. The current vote count is 5-2. Call the absent members.
Senator De Leon.
Aye.
De Leon, aye. Desaulnier.
Aye.
Desaulnier, aye.
That vote has 7. That bill has 7-2. All members are present. That bill passes. That bill is out. We have item number 9, SB 233, Pavley Emergency Services and Care. Its due pass is amended to appropriations. The current vote count is 5-0. Call the absent members.
Senator Allquist. Aye. Allquist, aye. De Leon.
Aye.
De Leon, aye. Desaulnier.
Aye.
Desaulnier, aye. Rubio.
Aye.
Rubio, aye.
Okay, that vote count has 9-0. All the members are present. That bill is out.
File item number 11.
File item number 11, SB 256, Strickland. That current vote count is 2-3. Its due pass is amended to appropriations. The chair is recommending a no vote. Call the absent members.
Senator Anderson.
Aye.
Anderson, aye. De Leon.
No.
De Leon, no. Desaulnier. Desaulnier, no. Rubio.
No.
SB 256, item number 11.
Rubio, no.
The bill is 3-6. The bill fails without objection. Reconsideration?
Sure.
Without objection, reconsideration is granted. Why? I just wanted to make sure you wanted to be reconsidered.
Let's do it again.
Number 14.
File item number 14, Lieu discrimination. The current vote count is 4-1. Due pass to judiciary. Call the absent members.
Senator Anderson.
No.
Anderson, no. Blakesley.
No.
Blakesley, no. De Leon.
Item number 14, SB 757.
Is it Strickland?
Yes.
No.
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 De Leon, aye. Desaulniers? Desaulniers, aye.
That vote is 6-3. All the members are present. That bill is out. Item 14? We have item number 13, 677, Hernandez Medi-Cal eligibility. The current vote count is 5-3. Due past appropriations. Call the absent members.
Senator Rubio? Aye. Rubio, aye. 6-3.
That vote count is 6-3. All members are present. The bill is out. We have some bills that Senator Rubio was absent on. We'll go ahead and lift those calls. Everyone else, we're done. But for item number 1, Alquist, SB 51, call the absent members.
Senator Rubio? Rubio, aye. 6-3.
It's 6-3. That bill is out. File item number 2, Price, due pass to rules. Call the absent member.
Senator Rubio? Rubio, aye.
It's 8-1. All members are present. That bill is out. File item number 3, due pass to appropriations, SB 135. Call the absent member.
Senator Rubio? Aye. Rubio, aye.
9-0. That bill is out. Okay, it looks like we're done for the business of the day. Let me thank everyone, and especially let me thank the staff for all the great work they did.
Confirm the mandate.
Just before we close, I want to confirm that we have the mandate bills that we're going to be closing without objection. That's SB 166 Steinberg and SB 255 Pavley. Any questions, concerns, comments? Thank you very much. We'll go ahead and adjourn.